to be honest with you, colleagues, I really enjoy her sessions. I have attended some of her sessions here in the Mpumalanga, and she's a very good, passionate teacher. And by profession, she's a medical doctor, with a master's in tropical medicine, and also diploma in HIV and obstetrics. She works in Mpumalanga, as I said, as an HIV and TB advisor, supporting our clinicians here in Mpumalanga, making sure that HIV and TB care is strengthened all across the province. And as earlier highlighted, very passionate about teaching, and especially when it comes to practicals and evidence-based medicine. She was very much enjoyed teaching, and then, as we highlighted, supporting clinicians to grow in confidence. And she's been a teacher for quite a while. And when you'll hear from the voice behind that, she's passionate about what she's doing. And I like her presentation in a sense that there are evidence behind whatever she teaches. We as clinicians, we always want to see evidence because things change, and there's a lot of evolution in terms of medicine. Without any waste of time, Chris, can you put your slides on the screen so that if you can see that we can see your slides?
Okay, let me see. I'm sharing.
Yes.
You can let me know if they're visible.
Yes, I think we can see it. Colleagues, can you all see it with thumbs up? Yes, I think we can see it. Christy, without any waste of time, let me hand it over to you and take us through the common mistakes that we make in TBK and how to avoid them. Thank you.
Great, thank you so much. Yes, when I was thinking of March being World TB Month, as you said, I was thinking, what could we talk about? And there are so many things in TB we can talk about. I couldn't decide to even restrict myself to one thing. So I decided to do a quick overview about many different things. So we're going to touch on many different topics tonight. It's just some of the things that I've come across practically in supporting hospitals and clinics, things where I've noticed sometimes we make mistakes. And I'm saying we, including myself and my colleagues, all of us are prone to make mistakes from time to time. But if we know where the mistakes are commonly made, then we can work towards avoiding them. So I'm going to dive right in with the first one. And I think you will all agree that we are lax when it comes to infection prevention and control. So let's remind ourselves how TB is transmitted so that we can remember why we should be doing our IPC principles. So when somebody who has pulmonary TB coughs, it produces droplet nuclei. And also, if we do certain procedures in the facilities, like if we do a bronchoscopy or we do sputum induction, those procedures produce aerosols. And in those droplet nuclei and in the aerosols, you find the TB bacilli. So now we can have larger droplets and we can have smaller droplets. So the larger droplets will have a higher number of bacilli. So you would think maybe they might be more infectious, right? But actually, because they've got a higher number of bacilli, they are heavier. So they don't remain airborne for long. It's a bigger droplet. The whole thing is heavier. So they drop down quicker. If we do inhale them, because they are big, our lungs can usually trap them quickly and they can be expectorated fairly quickly. The smaller droplets, however, even though they contain fewer bacilli, they are actually the ones that are highly infectious because they remain airborne for long periods. Even if somebody already left the room a while ago and you walk in there, you might be in contact with those small droplets. And when you inhale that, because they're small, they can easily reach deep into the lung, into those alveolar spaces where they can start replicating. So actually, the smaller ones are more infectious compared to the larger droplets. And then if we think of the type of TB patient, a patient with smear positive pulmonary TB will be the most infectious. Obviously, 3 plus more infectious than 1 plus. If they've got smear negative pulmonary TB, so the smear says AFB not detected, even though the gene expert or the TB NOT was positive, that one can still be infectious, but much less compared to the ones with 1, 2, or 3 plus AFBs on the smear. And then our patients with extrapulmonary TB are almost never infectious, unless, of course, they also have pulmonary TB. But if they don't have a pulmonary component, maybe they only have TB abdomen or TB spine, they are not infectious because they are not producing those droplets that we can inhale. Obviously, some people can have both. So just because someone has extrapulmonary doesn't mean they also have a pulmonary component. So we definitely have to consider all aspects of the patient's disease. So this is how TB gets transmitted. What should we do in our facilities when it comes to patient management? So there are certain things we should have in place to make sure we separate and manage our patient flow very well. So firstly, all of our patients should be screened. Those who are coughing, those who are having TB symptoms should be a bit separate in the queue from those who are not having those symptoms. We should educate our patients on cough hygiene. They should put their arm in front of their mouth. In COVID times, I think we all learned a bit about all these IPC, and the general public might have become a bit more attuned to some of these things, but not coughing into the air, not coughing in your hand that you're going to use to touch the next thing, but coughing into the shoulder or into the elbow or into a tissue or something like that. We should separate and isolate patients who are actively coughing from the ones who are more vulnerable or not coughing, and we should fast track them. We should see them quicker so that we can deal with them, manage them, investigate them, and get them out of the facility where they won't be infecting others around them. If they are symptomatic, we should do all our investigations, which we'll touch on later. We should treat them quickly if we diagnose TB, and we should have a clear discharge plan. Remember, when we discharge a patient from hospital, it's not to say that they are non-infectious if we have newly diagnosed them. So we should have a plan with that family, or with the patient and his family. Where will he be able to stay to avoid transmitting to more additional family members? So those are things relating to patient flow sort of things. But then we also have our environmental control measures. So we've got different types of ventilation we can use. Natural ventilation, which just means we open windows to get fresh air in. And we can also direct airflow with fans and with air conditioning. So important, it's not just about having a fan or having a window open in your consulting room. It's about the direction of the airflow. If you look at this little picture here at the bottom, let me just get my pointer properly. You can see here, if you've got your desk here, healthcare worker should be towards the side of the window or the fan, and the patient should be on the other side, so that the airflow will be in the direction from the healthcare worker to the patient and never in the opposite direction. We don't want the fan to be stationed here, for example, where the fan will blow air from the patient to the healthcare worker. So make sure, go back and check where's your consultation room set up, where's the aircon, where's the window, where's the fan, and make sure it's set up to protect yourself from potential infections. There's other things as well that we can use, these high efficiency particulate air filtrations in some of our facilities. We've got the ultraviolet irradiation. We know that TB bacteria can be killed by ultraviolet light, and it must be a real ultraviolet light, not just a purple glass around the normal light bulb. Ultraviolet lights are special lights, but they are helpful in these cases. So if you have them in your medical wards, that's great. And then, of course, our masks, our personal respiratory protection. We are all guilty of not wearing them always when we should. So remember the N95 respirator masks, those are the ones that are designed to filter out the droplet nuclei to protect us as healthcare workers and also from visitors, to protect visitors from inhaling these droplets. And it's not just putting it on, it's a bit of a process. There's whole training steps available for this. But you need to do your fit testing. You need to know the correct technique for putting it on. You need to check the seal to make sure that it's not leaking air. And when you take it off, you should take it off safely. It's not necessarily a single use. We can reuse these masks for a few days unless they become soaked or dirty. We can keep them in a brown paper bag because I know sometimes they are quite difficult to get hold of, or we have low stock levels. So if you have your own mask and you put it in a brown paper bag safely, you can reuse it for a few days until it's time to then dispose of it. Surgical masks, on the other hand, those are the ones that are more for the patients. It captures the droplets that the patient is coughing out or sneezing out so that those droplets don't reach the room so easily. But drops can still enter through the surgical masks. So, as healthcare workers, wearing a surgical mask, I suppose it's better than wearing nothing, but it's not nearly as good as wearing an N95 respirator if you want to protect yourself. Just as a reminder, the difference between the two: a normal surgical mask reduces transmission because it captures those bacilli that a patient is coughing out, where the respirator reduces our exposure to the bacilli in the air before we inhale the air. The surgical masks should be for patients with TB symptoms or diagnosed TB with smear positive, and the respirator should be worn by healthcare workers, health facility staff, and visitors to the TB ward. And the masks can be used in waiting rooms, consulting rooms, if the patient is leaving the ward, also if he's being transported, and even at home if the patient cannot isolate from other household members who are vulnerable. So if there's not good ventilation, there are young children or people living with HIV in the household, then we would advise the smear positive TB patient to also wear a mask at home, where the respirator would be used in TB wards, sputum induction areas, and other high risk areas. And also during transportation, the driver or other passengers who don't have TB can also be given these masks, and even community healthcare workers or somebody who's going to visit the patient, they can wear respirators. So remember to protect yourself with all these different measures. Let's not forget about IPC, infection prevention and control. So that is the first common mistake, which I think we can all agree we have made sometime in the past. Okay, number 2. Second common mistake we sometimes make is we forget to give TPT. I think we've become a lot better with TPT in recent years, but there are still some patients that end up slipping through the cracks. So let's remind ourselves who exactly is eligible for TPT. So firstly, if we look at people living with HIV, the eligible ones would be those who are newly diagnosed with HIV, as long as they are above 14 weeks of age, so adults and children. If they are on ARVs, but they've not completed a routine course of TPT before, we call this catch-up TPT. So every HIV positive person is eligible for at least one course of TPT in their lifetime. And then also contacts of, I think I made a typo here, people living with HIV who are TB contacts. So if a patient who is known with HIV has if you have a baby with a birth PCR or a 10-week PCR positive, we won't give them TPT immediately. We'll wait until they are at least 14 weeks of age, and then we will start their first routine course of TPT, as long as there are no other contraindications. And let's quickly look at the available regimens we have for TPT, because we actually have a few different options these days, not just INH like we used to. So the first one there in the top left corner is 12H, which means 12 months of INH. So people living with HIV above 25 kilogram can get this. Doesn't matter if the viral load is suppressed or not. Our pregnant women, where the CD4 is less than 200, they are eligible for the 12 months INH. Breastfeeding women who are living with HIV, and then also newly diagnosed people living with HIV. If they are initiating TLD, then usually we also prefer the 12 months INH for the TPT regimen. Then we also have 3HP, which is 3 months rifapentine and 1 month and INH, which is our weekly doses. Remember, it's 12 weekly doses. That one we give to people living with HIV above 25 kilograms, as long as they are virally suppressed. And the reason for that is because there's a bit of a interaction between rifapentine and dolutegravir. Rifapentine can slightly drop the dolutegravir levels. So we want to make sure the person is adhering well to their treatment before we give them 3-HP. If the viral load is high, we are suspecting there might be adherence challenges. So there's already a lower level of DTG in the body. So then if we add on rifapentine, it might drop the DTG even further. So that's why we prefer the viral load to be suppressed. We can also give 3-HP to HIV negative people who are TB contacts. Then we've got 6 months INH. That one we can give to HIV negative people who are TB contacts, and also to children living with HIV if they are below 25 kilograms. So they can also get the 6 months INH regimen. And then we've got 3RH, which is 3 months rifampicin and INH, and that we can give to HIV negative TB contacts and to other HIV negative at-risk groups, like people who had organ transplants or other immunosuppressive conditions. So you can see there's quite a few different options that we can use. We should discuss with the patient if there's more than one option that they are eligible for, discuss which one they would prefer based on the duration and the dosing frequency. Okay, so that was our second common mistake, forgetting TPTs. Let's not forget TPT. The third mistake we sometimes make is we only think of TB when the person says to us, I've been coughing for more than 2 weeks. That's kind of the main thing that stands out to us. And there's actually so many other times we should be thinking of TB. So remember, we use the FAST approach. FAST stands for finding people with TB actively, separating them safely, and treating them effectively. So part of that is when we should screen for TB systematically. We should screen the general population, especially those people with risk factors, household and close contacts, inmates, people living with HIV, people exposed to silica. And how do we screen them? We screen them through symptom screening. We've got digital chest x-rays, and these days we've got all these computer-aided detection software programs where you will take the digital chest x-ray and the computer software will give us an interpretation and tell us if there are TB signs and symptoms on that x-ray. And then we've also got our molecular rapid diagnostic tests. So we should be using all of those. TB symptom screening tool, just as a reminder, I'm sure you all know this. This is one example of a TB symptom screening tool that we can use. So it's asking all those standard questions. Do you have a cough? Have you been losing weight without trying? Are you sweating a lot at night? Do you have a fever? And the cough is not just a 2-week duration cough. In a person living with HIV, any duration of cough is a TB symptom and should warrant further investigation. So who should we then test for TB? If we say we should think of TB not only when the cough is more than 2 weeks, who else should we also test for TB? So we are using the Targeted Universal Test and Treat strategy, or TUT, and that means in the general population, we will test anybody with at least one TB symptom. People living with HIV, there's a few different places we should test them. At the time of HIV diagnosis, all these patients should, together with their baseline bloods, they should also get a baseline TB NOT. Anybody with confirmed or presumed advanced HIV disease should also get a TB test. Any person living with HIV with any TB symptoms, pregnant women enrolling in antenatal care should also get a TB NOT as part of their baseline booking bloods for their pregnancy. Then our people living with HIV should actually get an annual TB NOT whenever we do our annual viral load monitoring. We should also be doing that annual TB NOT as long as they are able to produce sputum. And of course, if somebody are disengaged from care and they are coming back into care, we are reinitiating them after at least more than 90 days of treatment interruption. Then we do our baseline bloods again. Remember, we collect the CD4 again for these patients as we are reinitiating them on ART. But we should also do a baseline TB NOT as part of those investigations. And then contacts. So any person living with HIV, has contacts, and those contacts should be tested for TB each time after exposure to a close contact or a household contact. And then people who were previously tested for TB should be tested annually for a period of 2 years. So obviously our people living with HIV, we're going to be testing them annually in any case. So this refers more to people without HIV. After finishing their TB treatment, we still will test them annually at least for 2 years. Okay, number 4. We tend to stop investigating when the first test is negative. Maybe we've identified that the person needs a TB test. We do a TB test, it comes back negative, and we are so happy and smiling like the person on this picture. We tell the patient the good news, you don't have TB, and we send them home. But GeneXperts or TB Knots are not 100% sensitive. We can miss a TB diagnosis if we only do one test and we are not following our algorithms properly. So remember, if you submit a sample for TB not and it comes back in TB not detected, it's not to say that's the end of your investigation. You've seen the patient initially, maybe he had TB symptoms, or maybe you were doing a routine test. Now he's coming back for his result. You still have to assess your patient clinically. Does he have symptoms? What is your physical exam showing? And if you have chest x-rays available, especially in a symptomatic patient, what does the chest x-ray show? And then we can decide if further investigation is warranted or not. If the patient has a clinical presentation or a chest x-ray that is consistent with TB, then we can start our DSTB treatment. And at the same time, we will collect a sample for culture and drug sensitivity testing. The TB NOD might have been negative, but the culture might still show something. So if it's a symptomatic patient, we're still symptomatic after maybe we've initially given them antibiotics or there's some time that passed, still symptomatic, we can start our treatment and collect a sample for culture. However, if the clinical presentation is not consistent with TB, then we can continue with routine care. And remember, there are other TB tests as well. Here we've mentioned the chest x-ray and we've mentioned the culture. But if it's a patient with advanced HIV disease or other indications of being really ill, we can also use a urine lamb. And that brings us to number 5 mistake. We underuse our urine lamb tests. We have them available in our facilities, but we forget which patients are eligible for a urine lamb. So what is a urine lamb again, or Aleph lamb? It's a point-of-care test that detects active TB in urine samples. It's quite easy to perform, gives us results in around 25 minutes, and the sensitivity of the test is higher when the CD4 is lower, especially if the CD4 is less than 200. So how should we do that? Ideally, we should get midstream urine. We should use the urine lamb kit according to the instructions, and then we should read that result between 25 and 35 minutes. Don't read it too early. Don't wait too long. Read it in the correct window according to the instructions so that we can get an accurate result. So who is eligible for a urine lamb test? If we think of our people living with HIV, so we only use lambs in people living with HIV, not HIV negative patients. If we think of our inpatients, those who are sick and admitted to the wards, doesn't matter if they specifically have TB signs and symptoms, but they are sick. It doesn't even matter what their CD4 is. They've got HIV, they are admitted because they are sick. They all need a urine lamb test. That's specifically for inpatients. Then on the outpatient setting, which could be the OPD at the hospital, the wellness clinic at the hospital, or the local clinic or CHC, in that outpatient setting, if a patient is living with HIV, they've got signs and symptoms of TB, and the CD4 is below 200, then we can do a urine lamb. Or if the patient is seriously ill, as long as you know it's a person living with HIV, even if you don't know the CD4 yet, maybe they are returning back to care or they're newly diagnosed, but you can see they are seriously ill, you're actually thinking of referring them to hospital for admission, that kind of ill patient. They are also eligible for a urine lab. And I've heard people get these things very confused sometimes. Sometimes we do a lab for every single person with a CD4 less than 200, regardless of TB signs and symptoms, and a well patient. That's not right. We are not supposed to do it for every single patient with a low CD4. Outpatient setting, low CD4 with signs and symptoms of TB, or a seriously ill patient. It's the hospital setting where it doesn't matter what the CD4 is and what the TB signs and symptoms are. As long as the patient is sick enough to be admitted to hospital, they are eligible for a urine lamb test. So urine lamb is a great test. It's got some strengths and it's got some weaknesses. So let's look at the strengths first. One of the great things is urine lamb is fairly easy to perform. It doesn't need a lot of training. You don't need to go and attend a 3-day training to learn how to use urine lamb. It can be a quick in-service training from a colleague who knows how to use it, and you're able to use the kit. Urine is also readily available. Unlike sputum, not all of our patients can produce sputum, right? But everybody produces urine. If they're not producing urine, they've got bigger problems than just being a TB presumptive case. So almost all of our patients have urine. It's a point of care test, so it allows us to get the result quickly. And if there's TB, we can initiate TB treatment immediately. Unlike sending a specimen to the lab and having to wait a day or 2 or 3 before getting a result back, we can get that result immediately after 25 minutes. It also improves TB diagnosis in severely immunocompromised patients. Those with very low CD4s, very weak immune systems, sometimes they are not able to produce sputum, they're not able to cough out, or maybe they've got a decreased level of consciousness, or they're not, even if they can produce sputum, it might be porcine bacillary. So there's not a high load in there, and it's not easy to actually detect TB in sputum for some of these patients. But we might be able to find it in their urine. And the other great news from the trials is that the urine lamb was the first TB test that's actually proved to reduce TB mortality in randomized controlled trials. So we really like urine lambs. Please use them whenever they are indicated, but keep in mind that they also have their limitations. On the limitation side, urine lamb is not specific for Mycobacterium tuberculosis. It just shows that the person has mycobacteria. It could be a non-tuberculous mycobacterium. It could be something like MAC. So if the CD4 is very low, especially those CD4s less than 100 or less than 50 even, think of other things as well. So yes, we will start TB treatment based on a positive urine lamb because that is our strongest suspicion and we want to save this person's life. But at the same time, getting a sputum sample for a culture becomes really crucial because we want to know that it really is Mycobacterium tuberculosis that we are treating. And with our second point, we want to know that it is drug-sensitive TB because urine lamb only tells us there's Mycobacterium. Even if it's tuberculosis, it doesn't tell us whether there's any drug resistance. Unlike the TB NOT, that will give us some indication whether it's drug-sensitive or drug-resistant TB. So we'll start drug-sensitive TB treatment, but we still really need our sputum culture to firstly confirm it's tuberculosis and secondly to confirm that it is drug-sensitive TB. The next limitation is, like we said, it's only for use in people living with HIV. It's really got limited sensitivity in patients with higher CD4 counts. And we even get calls now and then of people saying they tested someone who's not HIV positive, and now they've got a result that they don't know what to do with. They're looking for advice. And it's difficult to give them advice because we are not supposed to be using it in people living without HIV. So stick to the ones that are indicated for urine lamb. The other weakness of urine lamb is that we can't use it for monitoring, same as with the TB NOT. It's a diagnostic test. We can't use it to check when does it become negative to see if the person is responding to treatment. So it's only for the beginning. Don't keep on doing it in a known TB case. And also, like we know, a negative urine lamb doesn't rule out TB. If it's positive, it's helpful. But if it's negative, it doesn't mean we've excluded TB. If the person is symptomatic, we still need to look further in other places to find if he does have TB. Which brings me to my next point. We sometimes forget to look for TB outside the lungs. We tend to focus on the sputum tests. These days we can do a lamb as well. Remember, by the way, a positive urine lamb doesn't necessarily mean the person has extrapulmonary TB. It could be pulmonary TB, just that it's excreted in the urine. So just remember that one. But TB can also be outside the lungs. And we can actually use our GeneXpert Ultra on specimens other than sputum as well. So any specimen that is of respiratory origin, whether it's cough sputums, but gastric aspirates, gastric washings, all of those we can send for GeneXpert Ultra. Lymph node biopsies, if the patient is coming with lymphadenopathy, a biopsy or even a fine needle aspirate, we can send for a GeneXpert. Tissue biopsies as well, and fluids. Any fluids that we aspirated, whether it's a joint fluid, pleural fluid, peritoneal fluid, ascites, pus collections, almost any fluid except blood, we can send for a GeneXpert. CSF as well. If you suspect meningitis in your patient, do include the GeneXpert as well to make sure it's not TB meningitis. And these days, with our new pediatric TB guidelines, we can even send stool samples. Children less than 10 years, we can send a stool sample for GeneXpert. And the reason for that is because young children usually struggle to cough out. So if they've got pulmonary TB, they struggle to cough out sputum. They end up swallowing the sputum. So the sputum then goes through the gastrointestinal tract, and we can find some evidence of TB in the stool. So a child with a positive stool sample is counted as pulmonary TB because we assume that that TB is coming from the lung. It doesn't mean the child has abdominal TB or something like that. But it's quite nice, quite a helpful thing in children that we can use these days. Just make sure of the collection technique. Ideally, one of the first stools in the morning, make sure it doesn't get contaminated with a nappy, for example, if it's a baby. But these samples can actually be stored for a few days at room temperature as well. So this family can even collect it at home and bring it to the clinic, and we can test children like that. Then we can do a TB culture as well. Blood samples, we can send for TB culture and drug sensitivity testing. So if you have a Bactec bottle, these big funny shaped bottles there, bottom left, or if you have the green top heparinized tubes, we can use those to do a TB blood culture. And we normally do that in our advanced HIV disease sick patients that are admitted in the wards if we're trying to find other ways of diagnosing TB, especially if they are septic or quite unwell. And then if we do any biopsy and we have a tissue sample, we can send that for a TB culture as well. Just remember, very importantly, that sample should be submitted in saline. Sometimes we just put all our samples in formalin. That's our default. Make sure that you have some of it in saline. If we put our tissue sample in formalin, it will kill all the TB bacteria. We won't be able to culture anything. So if you want to grow anything, please don't kill the bugs that you're trying to grow. Put it in some saline and send the saline one for TB culture. Fluid samples, we can also send for cytology. And then tissue samples, we can also send for histology. So if you want to send for histology, this is when you will send the specimen in formalin. Now, we don't care if they are live or dead bacteria. We are trying to look at the structure of the tissue sample under a microscope to see if there's granulomatous lesions or other changes caused by TB. So if you have a bigger biopsy specimen, divide it into parts and send them for different things. You can send one part for GeneXpert, one part for culture, one part for histology, for example, but make sure that you send it in the right mediums. And then we can also do imaging studies, of course. So we can do a formal ultrasound or an informal bedside ultrasound. Those are quite useful for abdominal TB. We are usually looking for enlarged lymph nodes, ascites, splenic lesions. That gives us an idea that there might be abdominal TB. And we can also see pleural effusions or pericardial effusions with ultrasound. X-rays, except for chest X-rays, if we're thinking of pulmonary, of extrapulmonary TB, we can use X-rays to look at bones and joints if we are suspecting TB there. In CT scans, that can help us to see a detailed evaluation of lymph nodes, the abdomen, the spine, and the chest. And we can also see abscesses and other organ involvement, or if there's bone destruction, like this picture on the side here. This person has TB spine. You can see here how those vertebrae are destructed from TB. Then we also have MRI. If we are lucky, maybe some of our big settings, we might have MRI available. that is the best option if there's CNS TB, so anything in the brain. If we're thinking there's a tuberculoma, an MRI will be your best bet to see that. It can also show meningeal enhancement if there's TB meningitis. And we can also use that for spinal TB or other soft tissue involved. So we won't do everything for every patient, of course, depending how the patient presents, what the problems are. We can do our targeted interventions there. Then the next mistake that we sometimes make, now we're going slightly away from clinical things, is we forget to follow up on contact tracing. What is contact tracing exactly? So if we say contact tracing, we talk about the systematic identification of people with undiagnosed TB disease or those with TB infection among people who were recently exposed to the index TB patient. So undiagnosed TB disease means they will need TB treatment eventually. TB infection means they don't have TB disease yet, but they might benefit from TPT. What is a recent exposure? If we say a recent TB exposure, we mean within the last 12 months. And then we can also talk about a significant TB exposure. So significant means it's a known exposure to an adult or an adolescent with pulmonary TB, and the person spent time in the same enclosed space at least for one night, one or more nights, or it can be frequent or extended daytime periods, especially if it was during the 3 months before that index patient started their TB treatment. So we know that they probably already had TB then, that shortly before they were diagnosed with pulmonary TB. So that would count as a significant TB exposure. We are specifically saying exposure to adults or adolescents, not young children, because young children, like we said, they don't cough up TB sputum that much. So even if they have pulmonary TB, they are not likely to be infectious to others around them. What do we want to do with contact tracing? We want to firstly test all these contacts to see if they also have TB or not. If we find contacts with active TB disease, we want to initiate their TB treatment as early as possible so that we prevent further community transmission. And then also we want to identify those who are infected with TB who might be at risk of developing active TB disease so that we can start them on TPT. So they've been exposed, they don't have TB yet, they will be eligible for TPT. We've got different records that we use for contact tracing. The TB treatment record of the index patient, that you are starting this patient on treatment, all their contacts should be documented at the back of that TB patient treatment record. So that can be household contacts, other people that they spent the night with, other people that they spent extended daytime periods with. Then we need to go and trace all these patients. So the TB identification register is our next record. So all the contacts that are being investigated for TB should appear on the TB identification register. People who are then found to be eligible for TPT and are started on TPT, we will then document that as well on the TB identification register. And if among these contacts that we go out to test, if we discover that one of the contacts actually also has TB disease, that person will then get their own TB treatment record as a newly diagnosed patient coming from the original index case. We'll open a folder for them and we'll keep on repeating the process. We will find out who are their contacts. There might be other people that they've been in contact with. And we sort of snowball out like that so that we can keep on testing and treating people who were exposed to people with active TB. Then slightly back to the clinical side, we are very quick to prescribe treatment once we've diagnosed TB. But sometimes we forget about drug interactions. So let's remind ourselves. I went onto a website called drugs.com and I looked up some of the common TB drugs. And I was actually shocked at what I saw. Look at those numbers. Those are the known drug interactions. Almost 800 known drug interactions with rifampicin, almost 800 with isoniazid, almost 600 with bedaquiline. Not all of those are major interactions. Some of them are major, some are moderate, some are minor interactions. Not all of them are with drugs that we commonly use. But that's a huge number of interactions. I don't know if I even know that many drugs, let alone know that there are interactions with them. So I just picked a few. I'm not going to give you all 800 interactions here. I've just picked a few that I think we are using commonly in our settings. So let's start with rifampicin. I hope we all know that rifampicin interacts with dolutegravir, and the effect is that it decreases the dolutegravir level. But we can get around it. We all know this one. We boost the dolutegravir by giving an additional 50 milligram DTG 12 hours later. So if the person is taking their TLD at 7 o'clock at night, then it means 7 o'clock in the morning they should get an additional 50 milligram of DTG. And that will be as long as they are on the rifampicin containing TB treatment and for 2 weeks after, so that we make sure all the last rifampicin is out of the body, and then we can drop the boosting and go back to the normal dose of TLD or ALD. Lopinavir, luckily we don't use that as often these days, but a lot of our patients previously took lopinavir. So it is still important that we know these interactions. Patients who are on lopinavir, we should actually, there's another typo, we should use the lopinavir, doubling the dose of lopinavir if they are on the Eluvia tablets, or if they are on the Kaletra syrup, we were supposed to boost them with additional ritonavir. So please make sure if your patients were previously on lopinavir and they were on TB treatment, check if the lopinavir was correctly adjusted, because if it was not and they had treatment failure during the time, it's quite possible that they might actually have resistance to some of these protease inhibitors. And of course, there can be cross-resistance. So if we ever want to use a protease inhibitor in future, it will be important to know this past history. Atazanavir is another protease inhibitor. This is one that we use now and then these days. It is available. Some of our patients who are having problems with dolutegravir, we can give them atazanavir instead. But atazanavir is also decreased by rifampicin. So this one, unfortunately, we cannot overcome with dose adjustments. We should just avoid it. We cannot give atazanavir and rifampicin at the same time. Darunavir is also a protease inhibitor, and this is one of our cornerstone third-line drugs. Many of our third-line patients are on darunavir. With darunavir, it also has the level decreased if they are on rifampicin, and we should also avoid co-administration of rifampicin and darunavir. If you have a third-line patient who has drug-sensitive TB, we can give them rifabutin instead of rifampicin. It's a lot more difficult to get hold of. It means you need singles of all your TB drugs, which can be a bit of a tricky situation. But we cannot give darunavir and rifampicin together. And then lenacapavir is our PrEP drug that is coming soon, our injectable long-acting PrEP. We'll be piloting that in some selected facilities during the course of the year. And unfortunately, rifampicin also decreased the levels of lenacapavir. So if we have patients who are on lenacapavir for PrEP and they then get diagnosed with TB, ideally we should be giving them additional lenacapavir injections and also the lenacapavir tablets when they start their TB treatment. This obviously will depend on if we have stock available. If we have low levels of lenacapavir stock, we might rather give them oral PrEP to cover them to make sure they don't get HIV while they are on their TB treatment. But if we have enough lenacapavir stock, we can give them additional len injections when they are on rifampicin. There's more rifampicin interactions. It can drop the amlodipine level. So if we have patients on amlodipine, we should monitor their blood pressure and adjust the treatment as necessary. It can drop carbamazepine levels. So if you have an epileptic patient who is on Tegretol or carbamazepine, you might have to adjust your carbamazepine levels or choose a different anti-epileptic drug. Rifampicin can also decrease hormonal levels. So if a person is taking hormonal contraceptives, they should use alternative methods like barrier methods or injectables. It can also decrease warfarin levels. So if you have a patient on warfarin who now gets diagnosed with drug-sensitive TB, you should monitor the INR and you might have to adjust the warfarin dose. If a patient is on amiodarone, rifampicin also decreases amiodarone doses, so we should either use an alternative drug or increase the amiodarone dose. This is for our cardiac patients as well. And then our proton pump inhibitor, like our omeprazole, the rifampicin also decreases their levels. So we should try to find a different antacid there. So there's lots more for rifampicin. I just chose those few. Let's look at a few for INH as well. INH can increase phenytoin levels. So if a patient is on phenytoin, they might get phenytoin toxicity if we keep them on the same dose. So we might have to decrease the phenytoin levels a bit that we are prescribing. It might also increase carbamazepine. So you see it's interesting, rifampicin decreases carbamazepine where INH increases it. So in a patient who is on Tegretol, who is starting TB treatment that contains rifampicin and INH, we will really have to monitor the epilepsy control. We might have to check carbamazepine levels and then either adjust it upwards or downwards depending on the patient. Our asthmatic patients that are on theophylline, INH can increase theophylline as well, so we should be careful using them together and also monitor levels if necessary. And INH can also increase warfarin levels. So where rifampicin decreases warfarin levels, INH can increase it. So again, you might have to monitor the INR and adjust the warfarin dose as necessary. So these are just a few. There are many, many more interactions. I would strongly advise you, if ever you see a TB patient who are on a drug that you are not very familiar with, a drug that you are not commonly prescribing, if you're not sure if there's an interaction, please check it up. There are many drug interaction checkers online. Just use one of them to see. Sometimes there might be a minor interaction. That doesn't mean we have to stop all the drugs. We might just have to check levels or check for toxicity, check for any side effects. But other times there's actually a big interaction and we do have to stop a drug or adjust levels, dosages, or even change to a different drug. So please don't miss any drug-drug interactions. Another mistake that we sometimes make is we don't monitor for side effects, or if we know about side effects, we don't report them. And I think many of us are also guilty of that one. And that includes all the different levels of side effects. So let's start with minor side effects. If a patient's complaining of anorexia, so loss of appetite, nausea, and abdominal pain after they started their TB treatment, that could be due to rifampicin or due to ethionamide. So we have to exclude other possible causes of their symptoms, check if they've got gastritis, any gastric ulcers, reflux, pancreatitis, those sorts of things. And then we can advise them to take their TB treatment with small meals or just before bedtime, and rather not on an empty stomach if they are experiencing those sorts of GIT or abdominal side effects. The patient can also stagger their tablets. So if they're taking a few tablets, they don't have to take all of them at the same time. They can swallow one tablet at a time and space it over a few minutes. They shouldn't take more than 30 minutes to take their treatment, but they can space them out over half an hour if it is giving them abdominal symptoms. We can also give them antacids and antiemetics if they're having reflux or if they're having nausea. If we've tried these and it's failing, we're not getting any responses, then we can refer the patient at this point. The other very common side effect is that discolored urine. As healthcare workers, we know that the patient's urine color changes, but if we don't tell them, they're going to get such a big fright when they go to the bathroom and see this funny orange color urine that they are producing. This is, of course, from rifampicin. We don't need to worry about that. We just need to warn the patient when they start treatment that it may happen and it is normal, and reassure them that they don't have to worry about it. When they stop the TB treatment, the urine will go back to normal color. It's not a reason for them to be concerned and interrupt their treatment. Another side effect could be joint pains, and this is specifically from pyrazinamide. We can reassure the patient that it's usually a self-limiting condition. We could give them low-dose pain medication like paracetamol or Brufen, but if it's more severe, then we can refer them. And then sometimes we have these peripheral neuropathy kind of symptoms, tingling, burning, numb sensation in the hands and the feet. This can be from isoniazid or ethionamide. We should try to prevent this. So this is why we give our patients 25 milligram pyridoxine whenever they are on INH. Patients who are at higher risk include alcohol abusers, pregnant women, diabetic and epileptic patients. And for them, we can even give higher doses. 50 to 75 milligram of iridoxine for your high-risk patients. You can even go up to, you don't have to stick to 25 milligram. We start with 25 as prophylaxis, but if they're symptomatic, we can increase that dose. So those are some minor side effects. Looking at some of the biggest side effects, if they present with visual impairment or visual loss, that is quite a major side effect that we should be worried about. It can be due to ethambutol or ethionamide, and in that case, we should stop the treatment immediately and refer them to ophthalmology or an eye clinic for a proper evaluation. Another major side effect is hepatotoxicity. We know our TB drugs can cause drug-induced liver injury or DILI. So if they present with any of those hepatic signs and symptoms like loss of appetite, nausea, jaundice, dark urine, discolored stools, pain in the upper right quadrant, we should be concerned about hepatotoxicity. It can be all of our drugs, all of our DSTB drugs. We have to rule out any other causes of liver failure, alcohol use, hepatitis B, all those things. But depending on the liver functions, we often end up stopping our TB treatment and giving them a liver-friendly holding regimen while we do our workup. There's a whole DILI guideline for this, so I won't go into detail about that. Then rashes, all of the TB drugs can cause a rash. How we manage it depends on how severe it is. If it's a very mild itchy rash, we can just give them an antihistamine or a topical cream. If it's a petechial rash, that could be due to rifampicin. We have to do a platelet count in that case to make sure what the platelet levels are. If the platelets are low, we might have to stop rifampicin and choose a different regimen without rifampicin and monitor the platelet count. It's not very common, but it can happen. And then the patient can also have an erythematous rash with the fever. We will stop the TB treatment in that case. If the rash improves, we can reintroduce the drugs one by one, similar to how we do after drug-induced liver injury. Monitor the patient, and if the rash starts again, we know which drug caused it because we know the order that we are introducing them in. And then, of course, we have to report our side effects. Doesn't matter if it's a minor or a major adverse drug reaction, we really should be reporting all of them. And there's different ways of reporting it. We've got these pharmacovigilance forms that we can fill in. All of our facilities should be having these adverse drug reaction reports. And filling in a form, remember, is not an admission of guilt. You are not saying I did something wrong and now the patient is having a problem. It doesn't mean there's any negligence involved. It means the patient had a reaction. And if we don't report the reactions, we don't know the frequency of them in the community, and it makes it more difficult to do patient education and teach our healthcare workers which reactions to find, to look for and to avoid. So if you have these paper-based forms, or if you have an electronic version of it, you can complete it and email it to SAHPRA. There's the email address at the bottom. You might also have your own local processes. If you submit to your facility pharmacist, it will go to the sub-district, the district, or the provincial pharmacist so that they can also keep a record. And we discuss these at our pharmacovigilance meetings as well. And then we also have an app. If you don't have the MedSafety app, you can find it in your app store or your Play Store. It's easy to download. It's free. And you can also report adverse events there. Form is there. You fill it in, you click submit, and it also goes straight to SAHPRA. So it's also a quick and easy way if you don't have the forms easily at hand. And then the last mistake I wanted to point out is more of a soft one, but so important. We don't prioritize patient education. We know what's going on most of the time as healthcare workers about TB. So when you have a patient who is newly diagnosed with TB, start by finding out what they know about TB. What do they think causes TB? What do they think it means to have TB? Do they know how TB spreads? What have they heard about curing TB? Do they know anybody who had TB and what happened to that person? You might find that this person had an uncle who died of TB, and now that you are telling them they've got TB, they are going into a depression already because they are already seeing that they are going to follow that same route as their uncle who died from TB. And that's not the case. There are so many myths and stigmas out there. Some people think they get TB if they are bewitched. Some people think TB is a chronic thing that you will never recover from. Somehow it spreads. So find out what they know first, and then reverse all those myths and stigmas that they might pick up. Then we get information. I don't know if all of you know this patient adherence plan. We use it in the HIV program whenever we newly initiate someone on ARVs, but it's not just for HIV. It's for all chronic diseases. If you look at the top here, the first step is to say, what are we educating the patient on? Is it HIV? Is it TB? Hypertension, diabetes, or other? We can use the patient adherence plan for all our chronic diseases. It's not just an HIV form. So even for our TB patients, use the patient adherence plan. The first session is on the day of diagnosis that we are initiating them. And then session 2 is at the first follow-up appointment. It takes us through things that we have to ask the patient, things we have to educate them on, and some strategies that the patient comes up with. So I just wanted to highlight a few things that we should include. It's in this form as well. We should identify their support systems. Who are they living with? Who do they trust? Who will be there to maybe be a treatment buddy or to send them reminders or encourage them if things get difficult? What plans are they going to make for future appointments? Is it easy for them to come to the facility? Do we need a community health worker to assist? Is there somebody else that can fetch their treatment on their behalf? Which visits do they need to attend in person, and which visits can they send somebody else? We need to educate them on those things. Medication schedule as well. How often should they take the treatment? What time should they take it? And remember, they can be a bit flexible with treatment. They must choose a time that works for them, whether it's in the morning or whether it's in the evening. TB treatment is once a day. And if they choose a time and a month later they decide the time doesn't work for them, they can change it to a different time so that it fits in their schedule. We have to teach them what to do if they miss the dose. So if it's a few hours later, then they should just take that dose as soon as they remember. But if they've missed the whole day, now it's already time for the next dose, they shouldn't double dose. They should then just take the next dose on time. How are they going to remember to take their treatment? 6 months is quite a long time to take treatment every day. How will they remember? Will they have a reminder on their cell phone? Will they be watching a certain TV program every day that they will remember? Maybe they put it by the kettle every morning when they wake up and they make tea, then they can remember to take their treatment. Or next to the toothbrush, or anything that's in their daily routine that they do every day that will remind them to take their treatment. How should they store the medicine? They shouldn't be putting it right on the windowsill in the 35-degree sunlight, right? It shouldn't necessarily be in the fridge. It should be in a place where it can be dry, away from insects, away from children, and away from extreme temperatures. What should they do if they get side effects? We've spoken about side effects. We should tell the patient which common things to look out for and when should they bring themselves back to the health facility if there's a dangerous side effect. What should they do when traveling? Ideally, they should come and get more treatment before they go so that they don't run out of treatment while they are traveling. What should they do if they are using substances? Ideally, if they are smoking, they should smoke less. If they have TB and they're taking TB treatment, or even stop smoking. But there might be other substances involved as well that we need to deal with. Maybe they're drinking a lot of alcohol, and if they drink alcohol, they might forget to take their TB treatment, or they might have worse liver symptoms because of the shared toxicity between heavy alcohol use and the hepatotoxic TB drugs. What about traditional medicine? A lot of our patients make use of traditional medicine. They should be really careful with that because that can also have shared toxicities with some of the TB drugs. And then we should explain the full treatment pathway. Now that we're initiating you, what does the next 6 months of your life look like? How often should you come to the facility? How are we going to test you? How are we going to decide when to finish your TB treatment? And we mustn't forget about our multidisciplinary team. A lot of our patients will need psychosocioeconomic support. So involve the social workers, in healthcare workers, adherence counsellors, lay counsellors, dietitians, nutritionists, NGOs, community-based organizations. There are so many other colleagues. It's not just up to doctors and nurses to treat TB patients. Some of them will need psychosocial assessments. Some of them will need support to get grants. Some will need counseling and mental health support. Others will need more education, nutritional support, all those sorts of things. So not every patient needs all of these multidisciplinary team members, but see your patient, see what additional support they might need, and refer them appropriately. So I think that was quite a mouthful. I hope we all learned a few things. I wanted to quickly recap some of the mistakes that we should not continue making in future. So the first one was infection prevention and control. We're all going to go back, make sure our windows and our fans and our masks are used appropriately. TPT, we're not going to TPT. We'll remember who's eligible and who's not and what regimens we can give them. We'll remember about TB testing, our targeted universal test and treat, which patients should be getting a TB test, not only those who are coughing. We won't forget to do urine lambs as well for those who are eligible for urine lamb. We won't stop investigating when the TB NAT is negative. If the person still has TB symptoms, we will continue looking for other evidence of TB, including looking for extrapulmonary TB if the person has signs and symptoms suggestive of that. When we start prescribing TB treatment, we'll check for drug interactions and make sure we dose adjust or avoid any major interactions that could cause problems. We'll warn the patient about side effects. We'll monitor them for adverse drug reactions, and we will report any adverse drug reactions in our pharmacovigilance programs. We will make sure we elicit all the TB contacts. We'll make sure they are traced and tested so that they can also either be started on TB treatment or on TPT. And we will educate our patients with all the different things we spoke about now, how to adhere to their treatment and what their treatment path is going to look like. So I'm sure there's many, many other things. And if we open up the conversation after this, I'm sure many of you can chip in with more other mistakes that you have made or that you've seen others make. We are here to learn from each other. These are a few things that I picked up. So I hope these things might also be helpful to some of you. As we celebrate the end of TB month, we've got the whole rest of the year to go and find all our TB patients. We want to end TB by 2030. So let's find them all and treat them all and make sure we don't cause any harm along the way. Thank you very much.
Wow. What a better way to end a TB month, Christy. Thank you very much, Christy. Before we get into questions, colleagues, there's one video that we want to play for the colleagues. It's based for the clinical care forum, clinical care platform. So I don't know, Imelda, is the video ready?
Yes, thank you so much. We will, colleagues, it's our upcoming events. Thank you, Dr. Modiba. We will be sharing with our colleagues our upcoming events shortly. Let me see if it allows for multiple presenters. Yes, it should. IT, if you can. Thank you.
Colleagues, while we are preparing the video, prepare your questions on the Q&A so that we'll deal with them after the video. Thank you.
Our diploma preparatory programs are also still open for registration, with the live coaching period running from April to June 2026. These programs are designed to strengthen clinical decision-making, build confidence in patient care, and connect you with other healthcare professionals. We also have an exciting Refer and Earn membership campaign currently running. Earn 200 Rand for every successful annual membership referral. Finally, an important community safety reminder. There have been scam attempts in some WhatsApp groups targeting members. To protect our community, all official updates will now be shared through our verified CCP announcements community. Please also remember that Clinical Care Platform will never call you to invite you to an event. Thank you again for being here today, and we hope you enjoy the session.
Great. Thank you, Imelda. Christy, are you still here?
Yes, I'm here.
All right, great. So we'll just run through the Q&A. So Zakura at 646 is asking in terms of the IV lights. He says, can we install IV lights or antimicrobial curtains in the wards? In terms
that would be great. Yeah, if you have UV lights, or I've never heard of antimicrobial curtains, UV lights I've seen, that would be ideal. You'll have to check with your facility management to see what they can organize. But yeah, that would be great, especially in the medical wards and the outpatient settings sometimes.
Yeah, that also could be in private, in public, in terms of budget. But anyway, the next one, it's in terms of isolation of patients. Udirile is asking, is it not necessary to isolate patients with extrapulmonary TB as they are not infectious? I think you have dealt with this one during the presentation, but maybe you can say something else.
Yeah, so if they only have extrapulmonary TB, if they don't have a component of pulmonary as well, then we don't actually need to isolate them. So if you have a patient with extrapulmonary TB, maybe he only has TB spine, no pulmonary TB, and you have another patient newly diagnosed with pulmonary TB, AFB 3+, they shouldn't be isolated together in the same room, ideally. Although the other one already has TB, but I suppose he could get a new pulmonary TB infection on top of his current TB infection. So yeah, the extrapulmonary ones, as long as they don't have any pulmonary component at that time, they are not infectious to others, so we don't need to isolate them in the same way. And even the ones with pulmonary TB, after they've been on treatment for a few weeks, they're also much less infectious. It's really only that time before they are initiated on treatment and the first few weeks on treatment that they are infectious, but they become non-infectious fairly quickly after a few weeks.
Wonderful. The next one, it's from Non-to-Me, so it's 648. She's asking, after how many years can you give TPT? I'm not so sure she meant after maybe repeating the TPT or after, I'm not so sure. But yeah, she says, after how many years can you give TPT?
Yeah, so if you talk
Maybe
about
after completing.
if we talk about age, that's from 14 weeks upwards. But if you talk about repeat TPT, if it's just a routine course of TPT for someone living with HIV, we only give them one routine course of TPT at the moment. Guidelines can always change. Maybe that will change in future. But for now, somebody living with HIV only gets one routine course of TPT. But then you can repeat TPT if ever you have a new TB contact. So if you have a new household member living with TB or newly diagnosed with TB, then that person can repeat TPT. And there's no time frame there. So even if they had TPT last year and now this year there's a household member newly diagnosed with pulmonary TB, you can repeat the TPT again. So some people might have a few courses of TPT in their lifetime if they are having close contacts with other TB patients during that time. It will just depend, but one routine course of TPT is the current guideline.
So Constable on 704, she's asking in terms of repeating ULEM in terms of for diagnosis. If you have done it before, would you do it yearly?
Yeah, so the question is about repeating a urine LAM in a patient with a persistently low CD4 count, like annually, for example. Not really,
Yeah.
unless if the person has TB symptoms. So if the CD4 is staying below 200, if the person has TB symptoms, then definitely you can repeat it, and not just yearly. You can repeat it whenever the person comes with new symptoms. But if they're completely asymptomatic of TB, then we wouldn't do a urine lab. We would stick to our annual TB NOT in that case. Again, I don't know, maybe guidelines will change. We've got new advanced HIV guidelines coming out. But at the moment, as far as I know, it will only be for those who are really sick, for those with a low CD4 with TB symptoms, not just for the asymptomatic ones.
Yeah, thank you. So Anonymous, I think we'll put the question together. She's asking in terms of resumption of duty after starting DST treatment, meaning when does the patient becomes non-infectious so that they can resume duty when it's on TB treatment?
Yeah, so it will depend. Okay, obviously, if it's extrapulmonary TB without a pulmonary component, then as soon as they are healthy enough to go back to work, they can. Some of them will be sick for a while and need to be booked off because they are, weak. But if they are well enough to go back to work, if it was extrapulmonary TB, they are not infectious. If it is pulmonary TB, it also depends on what their smear showed. Someone who was 3+ positive might take longer than someone who is 1+ or smear negative. I don't know if there's a specific timeline. If there's someone in the TB program, they can tell us if there's an official guide on that. But I think it's a few weeks, as far as I know. It's like 2 or 3 weeks on TB treatment. You should be much, much less infectious and could potentially resume duty. They could still wear a surgical mask if that makes them or the people around them feel more comfortable, but they don't have to wear the surgical mask for the whole 6 months of TB treatment, for example. It will be for those first few weeks. I don't know if you want to add anything to that from your experience.
Yeah, normally you're right. In terms of 2 weeks, in most cases, they are more non-infectious, some of them. So yeah, I think you're right. 2 weeks, most of them are a bit infectious, non-infectious.
Then some of
Doctor,
them are really sick for a longer period. I know I saw a patient a couple months ago that after a month he was still, clinically not really well enough, and he had a manual labor kind of job. So we couldn't just let him go back to do manual labor. We had to book him off for a bit longer until he recovered. And then I think about 2 months later he was much, much better, and then he went back to work. So there's a clinical component as well.
yeah. So Dr. Kabongo on 739 is asking, okay, firstly, he said, thank you so much for the presentation, but he wanted to find out with symptomatic patient, should you send samples straight away for GeneXpect and culture at the same time, or should we go step by step, start with GeneXpect, then culture afterwards?
Yeah, that's a tricky one sometimes because we have the patient and we know cultures take long, so we want to get it quickly. I think ideally we should go stepwise. I know some people just do it all together. If they can get a lot of sputum at once, they will send it all together. But I think our algorithms are more of a stepwise process. But I do understand the reasoning behind wanting to do it at the same time, because if your TB NOT comes back negative, then at least there's still a culture that will come out to show you something. And if your GeneXpert was positive, then maybe the culture will show you something different on sensitivity. If the GeneXpert was fully sensitive, then the culture might not show you anything different, really. Then for a TB patient, we would collect the culture in any case. So I do understand the reasoning behind wanting to do them at the same time.
Yeah, wonderful. Anonymous is asking at 741, how long should one wait to start IPT after completing the TB treatment? That's a common question.
Yeah, so as long as it is drug-sensitive TB treatment, they can start TPT immediately the next day. So they can complete their TB treatment today, and tomorrow they can start TPT if they've not had their routine course of TBT yet. They don't have to wait. If it was drug-resistant TB, then it's different. Then they don't get their normal TBT. But if it was drug-sensitive TB treatment, it can be immediately the next day.
Wonderful. Luyanda Manana S741 is asking if what do you do or if the TB NAT says trace, but the patient has no symptoms of TB and never treated for TB before. What do we do?
Yeah, I think there was a time that we said any trace means TB. We should start TB treatment. But if the patient is completely asymptomatic for TB, and and obviously the reason why Leanda is asking about the never treated for TB before, if it's a known patient with previous TB, a trace could just mean that it's that sign of the previous TB, not a new infection. But in someone who never had TB treatment before and they are asymptomatic, I think usually we don't start treating them on a trace result. We usually repeat that. And then I would definitely repeat the NOT and do the culture to make sure we're not missing anything. If the patient has symptoms and there's trace and no previous TB, then we could initiate TB treatment. But in a completely asymptomatic patient, those that we are only doing it because of targeted universal test and treat, not because they are symptomatic, it does warrant some further investigation.
All right, thank you, colleagues. We're just gonna take 1-2 questions and then we'll wrap it up. Kathy has got a case here. I think she had encountered. She says she has 2 older patients with comorbidities who have household TB contact. Their sputum GeneSpect is negative. So she's asking, is the chest X-ray needed here? Because both of them are not keen on TPT.
Okay, so there's different issues involved here with these
Yeah.
cases. A chest X-ray would be if we think these 2 older patients, if we think they have TB because of their TB exposure, then a chest X-ray would help us to diagnose TB so that we can start TB treatment. TPT would be if we've excluded TB. So the negative GeneXpert is a great start. A chest X-ray that is clear will also help us that they don't have TB disease, but that still wouldn't take away the need for TPT. So obviously we can't force anybody to take TPT. We can explain the risks to them. If they have a household contact with TB, they are already older, they've got comorbidities, their risk of getting TB and having complications of the TB will be higher. So I think the key thing to explain to them is that sort of risk benefiting and the different TPT options that we have available. So if these patients are HIV negative household contacts, they've got shorter regimen options. They could take 3HP, they could take 6 months of INH. So it's not that they have to take 12 months of daily INH, for example. Even if they are living with HIV, if they're on treatment and suppressed, they could get 3HP, which is still a short course. So comparing that sort of short course 3-month TPT option compared to getting TB disease, where you have to take daily treatment, multiple tablets for 6 months and deal with complications of TB, it might be a small price to pay. So I think it's worth investigating them properly to make sure that they don't have TB that should be treated, and an X-ray could help in that case. But if we don't think they've got TB, they sound like they should benefit from TPT. So I think it's just educating them. And if they decide not to opt for TPT, we can't force them. Then we just have to monitor them and maybe retest them for TB a couple months down the line, especially if they become symptomatic. But maybe we can explain the different options to them and they can choose a regimen that they would be willing to take for a shorter period to protect themselves.
All right. There are 2 questions, but I'll combine them and make it one. It's for Anonymous and Jabu Kunene. He's asking in terms of patients who, so is the patient, if he diagnosed ULEM and they can't produce sputum, how do you rule out its resistance? And then together with the TB patient who is not on treatment, how accurate is the ULAM test? how accurate is the ULAM test for query TB patient who is not on treatment? And then also, if the patient can't take out sputum, how do you rule out resistance in those patients who have ULAM positive?
Yeah, so the accuracy, though, that's about sensitivity.
Yeah.
It's more sensitive with lower CD4 counts. So if you say a query TB patient, it will depend. Hopefully, it's someone who is living with HIV, because otherwise we shouldn't be doing urine lamb. And then it depends how low the CD4 is. It's accurate when we find TB, but like I said, a negative urine lamb cannot rule out TB. So it depends what exactly you mean with accuracy. If it is positive and we've done the test correctly, remember there can also be mistakes doing the urine lamb test. There can be issues with the quality of the kit. So if it was stored correctly and the test is done correctly, the result is read at the right time, and it definitely shows TB, then we can trust that there's some kind of mycobacterium. But like I said, we won't know if it's Mycobacterium tuberculosis or any of the other non-mycobacterium conditions. So that's why we should follow up with a sputum, which brings us to Jabu's question. What should we do if they cannot produce a sputum? How do we rule out resistance? Well, we can't really. If we can't find any other specimen to send, I mean, I showed you all those places to look for extrapulmonary TB. But if they don't have any lymph nodes or any lesions or any other things that we can send, then we just treat them for drug-sensitive TB. But we have to keep that index of suspicion that we should know we haven't actually ruled out resistance. So if the patient improves clinically on his DSTB treatment, he's gaining weight, his symptoms is improving, he's getting better, then we are fairly confident that he had drug-sensitive TB. But if we start DSTB treatment and he maybe gets a little bit better, but not really, and a couple months down the line, he's not really gained weight, not really much better, then we really have to start questioning, was it really TB? Is it not maybe drug-resistant TB? And then maybe try again with other samples, maybe try again to induce sputum. So that's why it is important to get that sputum initially, but I know some patients cannot produce. So then we just have to monitor them clinically, and that will guide us to some extent.
All right, colleagues, it's 7:58. I think we'll complete it at 8 o'clock. So I want to take one more questions and we'll be done for a night. Chris, the question comes, if the patient tested expect negative or TB not negative, and would you start treatment on them while waiting for the culture?
Where is this question? Let me just find it as well.
It's on Chabulula. Where is it?
What time is it? So if the expert is negative, but they're symptomatic.
Yeah. Yes. Why is this thing not going up? Sorry, I want to find out where.
Okay, I think I found it. Yes. Yeah, patient with symptoms, gene expert negative.
So in 53.
Yeah, you can. So, I mean, that's what the algorithm is showing. Obviously, it depends on your patient's whole total picture and if you've confirmed or excluded any other conditions. So if the patient initially presents, let's say they're coughing, you're not sure if it's just a bit of a pneumonia or flu or TB. If you think it's a pneumonia, you might give them some antibiotics. You do your gene expert, you follow them up after a few days. If there's no improvement on the antibiotics and the gene expert is negative, but the person is still symptomatic, if you have x-rays available, that is ideally when you would do a chest x-ray as well. And again, examine the patient properly, make sure there's no other extrapulmonary TB symptoms that you could investigate further. But then you would collect your culture and you could start it will be a clinical decision, right? But you could start your TB treatments at that point because the person is still symptomatic. And then you will wait for that culture result. If the CD4 is low, you can do a LAM as well. So look at all your different things, x-rays, LAMs, any other extrapulmonary investigations you can do. But you could start empiric TB treatment. But it's really important that you then follow up that culture and follow the patient's clinical improvement. Because again, if the person does not improve on your empiric TB treatment, there might still be another diagnosis. We did a mortality audit once a few years ago, and there was a couple patients that we found that actually had lymphoma, but they were misdiagnosed as TB because some of the symptoms overlap a lot. So starting empiric TB treatment doesn't mean we've decided it's TB and we stop looking for anything else. We still need to monitor the patient clinically to see if they are improving and check that culture result. And if we decide our diagnosis is not correct, we can change our treatment plan accordingly.
Wonderful. Thank you so much, Dr. Christy Jackson. I think you just nailed it on the spot in terms of the TB and then all the 10 common mistakes that we make. And I was also feeling guilty when I realized some of the things that I know we normally make. So yeah, but thanks for the information. It was a very informative and practical presentation, and I've learned a lot, and I know colleagues also learn a lot. And I know it's not going to stop today in terms of the TB. We're going to continue until we reached our target in terms of ending the TB. Any final words, Christy, before we close? I think we have gone beyond 2 minutes past 8.
Yeah, when I was doing this, when I was putting this presentation together, I was just thinking there's really no space for attitudes or ego in medicine. We all make mistakes. And we should be humble about that. We should look for those mistakes, not because we want to judge others or throw people under the bus. It's because we care about our patients and we want to improve that. So if you see a colleague is making a mistake, help them in a nice way, point it out to them, but not in a way that will make them feel bad, just to educate them to avoid making that mistake in future. And if somebody tells you that you made a mistake, or if you discover, maybe you attend a webinar, you read a guideline, you discover you've been making a mistake, admit that and tell your colleagues, I've done this, I'm going to do that differently now, because your colleagues might be making the same mistake. So don't take it personally if someone says to you, this thing was not done, according to the best evidence. Take it as a learning opportunity. We are all just human. We all make mistakes from time to time. Obviously, we want to do the best for our patients. So let's learn and improve our care for the benefit of our patients.
Thank you so much, Christy, for your time. We appreciate your presence and then even the information you've given to us. Colleagues, thank you for joining us until this time. Your time and dedication is very appreciative. And then I think you're also gonna do a great work with your patients, and then all the best in terms of your work. And good evening, all of you. Good night.
Thank you so much. Good night.
Our diploma preparatory programs are also still open